All right. Well, I would like to thank everybody who is tuning in tonight for what I hope will be a really interactive discussion. So it's Thursday night. I'm on Pacific time, so I think many of you are tuning in a bit later. So I'd really like to thank you for joining in. So my name is Dr. Chap. A little bit of my background, I'm from the Midwest, did all of my training from University of Illinois all the way to Northwestern, University of Chicago, and then came out to UCLA and was spoiled by the weather. So I've been here since 1994 or so. Did spent many years at UCLA, and really it was during that period of time in my fellowship that I really became very attached to the breast cancer patients, really became my passion. And I've been doing this for 20 years, and essentially 100% of my practice is breast cancer. So very passionate about it, love my patients. And even though I've thought about joining pharma maybe someday, I really would miss my patients. So don't think I'll do that. So tonight, what we'll be discussing is what's called the Breast Cancer Index, which is applicable to patients with breast cancer. I think the timing is perfect given that it's Breast Cancer Awareness Month. Everything is pink. You should see my offices, my patients' pink sneakers. So really an important time to bring awareness to this disease, which is so prevalent, as we know, affecting about 1 out of 8 women. So I'll be going through the purpose of this test, some background about what we refer to as hormone receptor positive, hormone receptor sensitive type breast cancer, and the applicability, how we use this test to make decisions about how long we use anti-estrogen therapy. And then there are 2 lovely women who will, join us to share their stories and their testimonials. And then, perhaps if time, we'll go through some question and answers. So this is just a bit of the agenda that we'll be touching upon tonight. So basics about what we refer to as HR, or hormone receptor positive breast cancer, how we utilize that to incorporate our treatment and treatment decisions for the disease. Very important, obviously, in terms of quality of life. How might we manage the side effects? I mean, almost with everything that we use, even Tylenol, there can be side effects. So how can we address some of these side effects and improve quality of life for women who are on anti-estrogen therapy? And a little bit more about what is the risk of recurrence and how we determine how long to use our anti-estrogen therapies. And as I already mentioned, we'll have 2 lovely women share their stories and some Q&A. All right, and that's my name, Linnea Chap. Okay, so to start with, let's go through some basics about hormone receptor positive breast cancer and the treatment we use. All right, so what is hormone receptor positive breast cancer? And this can be a bit complicated. And I know that the majority of women who are diagnosed with this disease, I mean, lucky if 50% is digested in terms of all the information that we try to provide, especially with that first meeting that clinicians have with patients. I saw one of my own patients today who said, well, a couple people have asked me if I'm positive or not. What are they talking about? So I had, a debriefing, with her today. So hopefully this will make sense in how I reported it to her as well. So often what you'll see is that in our dictations, for example, in our charting, physicians love to use acronyms. We have so many long words that we abbreviate all of them with letters. So we'll write down HR positive breast cancer. What does that mean? Well, that stands for hormone receptor positive breast cancer. And what we're referring to is 2 different receptors. And that's what we call the estrogen receptor and the progesterone receptor. So there are 2 entities that we look at in the pathology report to give us this information. All right, so let's go through some of the basics. And, I'm not a person to read words, off of a slide word for word, but how do I really sit down and explain this to a patient? So if we look at the normal breast tissue, and really what we're talking about today is looking at these receptors in breast cancer. So when we talk about these receptors, how I like to explain it is that these are proteins, these receptors that are on the cancer cell, and within the cancer cell. And it's important to know about these because what happens is that these particular proteins or receptors, when estrogen or progesterone, which are largely the female produced hormones, when they attach to these proteins or receptors on the cancer cell, essentially what happens is a signal is being sent to the control center of the cell that tells that cancer cell to grow and divide. So another analogy that I give that I think makes sense is that what one can think of about these receptors is that they are like locks on the cancer cell. And estrogen that's in the bloodstream is like a key. So when estrogen gets to that lock, the lock is turned on, and then again, a cell is told to turn on, to grow and divide. So that's why it's so important to know if a cancer is hormone sensitive or positive or not, because we can take advantage of that in terms of the treatment that we have. And when we look at all patients who have breast cancer, roughly about 2/3 of patients with breast cancer have disease that's what we refer to as being hormone receptor positive. So 2 out of 3 women. All right, so in terms of how do we take advantage of this and the treatment that we use for hormone receptor positive breast cancer, as I already mentioned, estrogen again attaches to this receptor and thereby turns the cell on. It's telling the cell to grow and divide. So we take advantage of that by using what are either estrogen receptor blockers or another group of drugs that are aromatase inhibitors. And again, another analogy that I'd like to give patients that I hope visually or, by hearing makes sense is that when we use these drugs, it's like taking water away from a plant. A plant needs water. So these estrogen receptor cells, they need estrogen to grow and divide. So again, in terms of our treatment, we have really two main groups. So they're the group of drugs that we call estrogen receptor blockers. So these drugs actually get to that receptor or that protein first so that estrogen can't get to it. So you're blocking that signal, telling the cell to grow and divide. And the primary drug that we use within this category of blockers is tamoxifen, which I'm sure so many of you are familiar with. Tamoxifen gets to that receptor first so that estrogen can't. There are two other drugs that are within this category called estrogen receptor modifiers. There's trimethoprim, and originally this drug was developed with the thought, at least in the laboratory or rats, that there would be a lower incidence of developing uterine cancer, but this wasn't found to be the case. And then there's another drug called Evista or raloxifene, and this is primarily a drug that we use to treat osteoporosis or osteopenia. And in the studies for those particular patients, there was a lower risk of developing breast cancer. So Evista primarily is used in those patients who are at higher risk of developing breast cancer based on family medical history and a whole slew of other things. But it really is too weak to use in the setting of known breast cancer. And then there are the group of drugs that we call aromatase inhibitors. And how these work is that in women, we're producing male hormone, believe it or not, we are. So we're producing male hormone or androgens. And when those androgens get to the fatty cells, there's an enzyme or protein that turns it into estrogen. So how this group of drugs work is that it actually blocks that from happening. So it keeps that male hormone from turning into estrogen, again, lowering the estrogen level so that you're starving the cancer cells. And there are 3 different drugs within this group of aromatase inhibitors, Femara, Arimidex, Aromasin, and essentially they're interchangeable. I've used all of them, and any one of these drugs really is equally efficacious. In this group of drug, though, what's important to know is that they really are only applicable to women who are postmenopausal. So they don't work in premenopausal women unless the ovaries are shut down, because we're only blocking what happens in the fatty cells, not what happens in the ovaries. All right, so we know these drugs are good. I'm not going, I could spend just an hour talking about the effectiveness. Tamoxifen goes back to the 1970s, very efficacious drug. And then the aromatase inhibitors came along, which were even superior to tamoxifen in postmenopausal women. So well established in terms of the efficacy, despite, the conspiracy theories that exist out there, but side effects can happen. So why potentially are there side effects from these drugs? Well, we're lowering the estrogen level. So menopause-like symptoms can happen. They're very different, across all women. Some women, they feel like they're taking just a water pill. Other women, their quality of life is really affected and they're quite miserable. So how might we manage these side effects? Right, and on the left here, we have a very busy wheel chart that's at least broken off a little bit. Well, there we go. So there are a multitude of side effects that can happen from these drugs. I tend to really focus with my patients on what are the most common things and tell them, boy, if you read about Tylenol, you would never take a Tylenol pill, but what are the most common things? And that's really depicted here, and it varies between which drug is being used. All right, so there are some unique side effects when we look at the different classes or group of drugs. One thing that's common to both the aromatase inhibitors as well as tamoxifen is hot flashes, and we'll be coming back to that. I'm sure the majority of you, or at least most of you, have been there, done that. Really can be, quite disabling hot flashes that I think very often the men out there don't quite appreciate, but really can affect quality of life and sleep and just general sense of well-being. But then things that distinguish the two different groups are tamoxifen and aromatase inhibitors, endometrial cancer or cancer of the uterus. And why is there that difference? Well, tamoxifen is actually a very unique drug in that, in terms of the breast cancer cells, it's acting as an anti-estrogen or a blocker to estrogen. But the uterus actually thinks that it's estrogen. And when you keep using estrogen without progesterone, there's a risk of uterine cancer. But the risk is quite low. It's really in the range of about 1 out of 500. I've only seen 2 patients, and I think it's been 20 years, who've developed uterine cancer. And one was actually had been on tamoxifen for almost 20 years. I had inherited her from someone else. And the other one was in a polyp and was cured. As far as aromatase inhibitors, very important is the risk of osteoporosis and developing bone fractures because our bones need to have estrogen and we're taking that estrogen away. Cataracts develop more early, it's more applicable to tamoxifen. Again, the bone fractures I already mentioned with the aromatase inhibitors. Blood clots, higher incidence with tamoxifen, pretty comparable to what we would see with hormone replacement therapy and women who are on oral contraceptives. Again, fortunately, quite rare, but it is higher, for example, than taking a placebo. And risk of heart disease might be a little bit higher with the aromatase inhibitors because we do see that the cholesterol can go up. So important to be aware of that because people can get very nervous, and even physicians who don't know about this potential side effect, suddenly the cholesterol is up on that lipid panel. All right, so what are some of the strategies that we might use for these anti-estrogen side effects? And when we have our patient testimonials, hopefully they haven't had side effects, or if they had, they can share their experience and other things that I might not be aware of. I find that I learn so many new things from my patients, so I'm always open to being educated and learning new things. So fatigue potentially can be seen with these drugs. Really important to have physical activity and to have a healthy diet, which all of us should be doing. But, it's always, maybe tomorrow I'll start getting to the gym. But even just touching for a moment on physical activity, there are studies showing that for women who exercise at least 150 minutes a week, and that really can be broken down into 30 minutes of cardiovascular moderate activity, 5 days a week, actually may almost have the same comparable benefit to tamoxifen, and it's good for your heart and so many other things. We have here on this slide nausea and vomiting. Fortunately, I've never had a patient report vomiting, but there can be a bit of queasiness, especially at the beginning with the aromatase inhibitors. I myself have never had to prescribe anti-nausea medicines. And sometimes patients will play around with the drugs a little bit. They might feel better if they take it in the evening and sleep through it versus taking it in the morning. So I think there are different strategies that can be spoken about with your doctor about how to address these side effects. Mood swings, I think that's a bit, in my experience, more common with tamoxifen. There can be irritability, and joke around with my patients. Well, at least your partner, you can tell them you have an excuse as to why you're, very irritable and moody. There are things like relaxation. There's an app called Calm, C-A-L-M, that can be very helpful. Meditation does work for me. My mind wanders, but some patients are really good at it. And for some, depending on where you're coming from, individual therapy or group support can be really good, in terms of the anxiety that comes with this disease and the diagnosis. Hot flashes, again, a biggie that's out there. I had a woman who was changing her nightgown 20 times a week and sort of poo-pooed by her physician. And, I talked to her about different strategies and actually put her on a low dose of Effexor, which is at the bottom of hot flashes there, which is a low dose antidepressant. And she thought that I walked on water. She had really remarkable improvement in terms of her hot flashes, but doesn't work for everyone. There are other medications, prescription-wise, that can be used. Neurontin is a medication that typically is used for neuropathy, sort of that neuropathic pain, numbness and tingling that can happen from chemotherapy, for example, can be beneficial for hot flashes. I just prescribed it for one of my patients today. Oxybutynin is another one that's not on here that in the past was used for women with the urinary urgency, bladder spasms and a bit of leakage. That can really be beneficial, but can cause dry mouth. Lifestyle things, important really to exercise. So cardiovascular exercise, also increasing your intake of what we call cruciferous vegetables, broccoli and bok choy can help with hot flashes, and limiting alcohol as well as caffeine intake. So a lot of things that you can talk to your clinicians about, and hopefully they're listening. Right, bone and muscle aches. I see a little bit of this with tamoxifen in terms of what we call arthralgias or joint discomfort. Much more prevalent, I think, with the aromatase inhibitors, this complaint of stiffness, achiness, most common after someone has been sedentary, so after sleeping all night. But I do occasionally have somebody say as soon as they sit down, when they go to get up, and the number is so common almost across the board, someone will say, I feel like I'm 90 years old. I did have a patient that was 90, and I said, you might feel like you're 100. What can we do about this? I think that there's probably pretty minimal benefit from doing things like ibuprofen and medications in that category. But again, learning from my patients, yoga, I think, is a good one, and stretching that can be benefit for this, and also swimming or pool therapy. So again, talk to your oncologist about your symptoms. I think so many people want to be the well-behaved patient and not necessarily talk about the symptoms that they're having. Another common one is vaginal dryness. Discharge is more common actually with tamoxifen, but vaginal dryness, is a biggie that I talk to patients about. And typically I have them start with, moisturizers that are over the counter. There's KY and some that have actually become much more natural than the old jelly that used to be out there. To start with that, Replens is something that can be used on a daily basis. Not really too impressed by the feedback I get from my patients. There's something called Mona Lisa, which is a laser treatment that a gynecologist can do. I've gotten mixed feedback about that one myself, but again, talk to your physicians about this. And this is a question I know that's burning, at least in somebody's mind, is whether or not it's safe to use intravaginal or estrogen. And that's something really important that you need to talk to your doctor about. Myself, I think you have to weigh quality of life, about the theoretical risk of absorption of the estrogen into the bloodstream. But if you talk to most gynecologists, what they will say is that once you build up the lining, there really is negligible absorption. And again, you always have to weigh quality of life issues with a theoretical concern about using intravaginal estrogen like Vagifem, which is a tiny tablet that can be done 2 to 3 times per week and really can improve the quality of life. All right, so let's talk a little bit about the risk of recurrence for women who have invasive breast cancer, and how long should the treatment be? All right, so what I really try to stress to my patients, who again, you're not listening to everything and hearing everything, that first meeting, but I think it's still so prevalent, not just with patients, but within the healthcare community, physicians, healthcare providers, that there's something really, there's something significant, obviously, about hitting that 5-year mark, but it's not the be all end all, and that there potentially can be a recurrence after 5 years. So about 50% or 1 out of 2 women who have breast cancer may have a recurrence beyond year 5. So when I talk to my patients, I always tell them it's going to be at least 5 years of using this medication. And as we get closer, we'll talk about whether or not we should consider having you stay on it beyond year 5. Right, and this is just a bit of a time outline in terms of the treatment, again, for hormone receptor positive, what we call early stage 1 or 2 breast cancer. So the first 5 years of therapy with anti-estrogen medication is what we refer to adjuvant therapy. It's adjunctive or adding on to the surgery that someone has undergone. And then when we hit year 5, any treatment beyond that with the anti-estrogen therapy is called extended anti-estrogen therapy because we're pushing it beyond that year 5. All right. So, in looking at the different studies, with more than 5 years of anti-estrogen therapy, again, these studies, they started because we were seeing relapses beyond year 5. So it was the logical thought of, well, let's compare 5 years, for example, to 10 years. Let's see what the benefit is. And there are many studies now that have looked at this. But if you look across all of these studies, they have a very comparable benefit in that taking the therapy beyond 5 years is a benefit to about 3 to 5 out of 100 women who push things out to 10 years. Now, for those 3 to 5 women, obviously that's of significant benefit to not have recurrent metastatic stage 4 disease, but that means 95 to 97 of women didn't benefit and might have to just deal with lower quality of life and side effects. So how might we better improve which patients we should treat for more than 5 years? Right. So this is just to give us an example. Traditionally, what as an oncologist I looked at in the past and what many oncologists still really utilize about what a woman's risk might be in terms of having a late recurrence, but looking at whether or not there are lymph nodes involved, how many lymph nodes, how big is the tumor, what is the tumor grade, how well behaved or not does it look under the microscope, pre or postmenopausal age, and there are different sort of genetic type tests that we can do. So all of these are important, but they really don't reliably predict who might recur after 5 years. So clearly emphasizing that we need a test or some tool to better predict which women we need to treat beyond 5 years, or at least to offer treatment. All right, so just to give us an example, a little bit about what we're talking about in terms of genomic testing. So some of you might be very familiar with what's called the Oncotype DX. And this was a tool that was developed looking at multiple genes within the tumor to assess whether or not someone would benefit from chemotherapy. So rather than having somebody in their white coat behind the desk say, I think you need chemotherapy or you don't, to really get more of a black and white answer as to what would actually be the benefit from adding on chemotherapy. So now we do have a test, what's called, again, a genomic test looking at different genes to help really sort through what will be the risk of having a late recurrence and would that person be a benefit from continuing anti-estrogen therapy after 5 years. All right, so this is the tool that we have now. It's called Breast Cancer Index. Complicated slide, but to really bring this down to basics is that there are 2 components to this test. One is that what is the predictive component? So really predicting or telling us yes or no, is that person likely to benefit from therapy beyond 5 years? And then there's the prognostic component of the test. What is that person's risk of having a late recurrence between years 5 to 10? So the report is great as a physician who's very busy. The report is so nice, I think, for patients as well, and that it's very straightforward. It really breaks things down again into those 2 components. Yes or no, will there be benefit in terms of continuing therapy beyond 5 years, and then that prognostic component, what is the risk of recurrence beyond 5 years up until 10? So for this particular patient, yes, there will be benefit, which is roughly about a 65% reduction in that bottom number. So this patient has an 11.1% risk of recurrence between years 5 to 10. So arguably by extending therapy, we're going to bring that down by 65%, probably closer to about 4%. And this is another report. No, this patient is not going to benefit beyond 5 years. And this patient has a distant risk of recurrence of 2.2%. Cup is half full or more, 98% chance that nothing is going to happen between years 5 to 10. All right, and this is just a busy slide, not to walk you through all of the minutia here, but thousands of patients have been studied in terms of looking at 5 years versus 10 years of therapy and utilizing this test, the breast cancer index, across all of these studies. So it really has been validated with a large number of publications and all. All right, and as far as the utilizing this test for making that decision about extending endocrine therapy, it's been recognized by two very large leading oncology institutions, so to speak, within their guidelines for making a decision beyond 5 years. So back in January of 2021, this was recognized by the NCCN, which is the National Comprehensive Cancer Network, and more recently by ASCO, or the American Society of Clinical Oncology, back in April of 2022. So it's a test that I've been using for years and really believe in. So really nice to get the nod from two big institutions like this. So how might this affect a patient? And even before that, there's not a slide on this, but they also did a study at Yale and asked physicians, once they had the BCI, what they would do. And at least 60% or so of doctors actually changed what they were going to do with the patient in terms of extended endocrine therapy or not. And then we've also looked at how does this impact what a patient decides to do. So having this test available, about half of the patients stated that they really had a change in their preference for treatment. It was associated with less anxiety. About 2/3 of the patients said they were less conflicted. They felt much more comfortable with their decision in terms of continuing therapy and their angst over whether or not to continue or to stop. So about 82% of patients stated that they really would be more compliant. And this is something when I speak to healthcare providers, there's another slide about, and up to 40% of patients are compliant with staying on extended endocrine therapy beyond 5 years based on the older data and not having this test. But just like the Oncotype DX, I think having something in black and white, it makes sense that, you know, we're humans. Having something like that that's more definitive versus a doctor sitting behind their desk, more likely to be compliant. And compliance really is associated with a much better outcome. All right, so now I'd like to hand things over to Michelle and Andrea so they can share their own stories with you.
Thank you, Dr. Chap. I will get started. My name is Michelle Beck, and I appreciate all of your examples. They were wonderful, and I've been in the breast cancer community for 10 years, so thank you for that. And okay, so I will give you a short version of who I am. So I am 51 years old currently. I've been in the breast cancer community for 10 years, unfortunately, but as we say, it is the worst club to join, but has the best members. So I was first diagnosed in December of 2012 with hormone positive breast cancer. I was very fortunate. It was caught on a regular mammogram deep within my chest wall, so I would not have found it on my own. I was stage 1, grade 1, very small tumor. And I have a family history of breast cancer. My grandmother passed from metastatic breast cancer. So for some reason, I always had a feeling in my head that I was going to be the 1 in 8, and I was. I opted at that time for a lumpectomy followed by radiation, and then I spent 4 years on tamoxifen. It was somewhat of a no-brainer to me to go with what my doctor recommended in terms of the tamoxifen. I was at that point done having children, and so we moved forward. And my side effects were not super bad on the tamoxifen. I did experience hot flashes. I definitely had some brain fog, and I had random leg pain in my right thigh, which I never understood why it was just my right thigh, but I'd be laying awake at night going, why is that hurt? Definitely had insomnia. It was not ideal having to take this medication to further prevent cancer. Great idea, but as Dr. Chap mentioned, there are side effects, and I really unfortunately have always been the poster child for side effects. Took tamoxifen for 4 years, and then unfortunately I had a new primary occurrence in my other breast. I can joke about it now, and I say that my right breast felt left out, and it was like, pick me, pick me. But more so, I probably just produced a lot of estrogen, and the cancer liked it in my body. So at that point, since I had had occurrences in both breasts, I opted to have a bilateral mastectomy with reconstruction, and I was given the option to either have my ovaries suppressed with monthly Lupron shots, which sounded awful to me because I've had my share of needles going on in my life at this point, or I could have my ovaries removed. I thought, okay, let's remove the ovaries because I don't need them anymore. Done having children. I was 46 at the time, and I was fairly good. Well, at that point, since I was not, the tamoxifen did not seem to work for me since I had a new occurrence while I was on it. I was put on the aromatase inhibitors since I was then postmenopausal after having my ovaries removed. I would say within 2 weeks, my side effects started to hit. And looking at the chart that Dr. Chap had put up, I literally had every side effect other than probably cataracts and high blood pressure. Joint pain, yes. Intense joint pain. I feel like my knees just stopped working. I had intense pain in my hands and my feet, and it wasn't neuropathy because I did not have chemo. My sleep was a disaster. I could not fall asleep. I could not stay asleep. Weight gain. Since I was diagnosed and had my mastectomy, I put on 50 pounds and I didn't change anything in my life, which I should have, but I was not as proactive as I should have been in terms of my fitness because the side effects that I was experiencing were precluding me from doing anything physical. It hurt to walk my dogs. It hurt to hold on to my leash because my hands hurt so bad. I could no longer ride a bike because my knees didn't work. It's everything that I was going through, other than the fact that it was preventing cancer in my body, was awful. But since had been through it twice, my doctor and I decided you are going to be on the 10-year plan. And emotionally, that really broke me because having side effects from day one on the aromatase inhibitors, it was so debilitating to my life. But I dealt with it because I have a young son. I didn't get married till late in life. I wasn't a mom till I was age 39. So my son was not even 2 the first time I was diagnosed. So I would do everything I could for my body to make sure that I didn't get cancer again. And that included the tamoxifen and then the aromatase inhibitors. As Dr. Chap had mentioned, there are 3 different kinds of aromatase inhibitors. I tried them all. I started with the main one, and I can't remember which one that is generally that everyone gets, the anastrozole, the Arimidex, I guess. And it was awful. Did that for a year. Took a month off, switched to the next one, took a month off, switched to the next one, because I was trying to see, are any of them better for me in terms of the side effects? And unfortunately, the answer was no. I will say honestly, what got me through this period was I found a support organization very close to where I work called Breast Friends, and I started volunteering there, and I met other women who understood what I was going through. And we were able to compare notes on the side effects, and I started using many integrative medicine therapies to combat the side effects. I'm a huge lover of acupuncture. I've tried natural I've done black cohosh, I've done for the hot flashes, I've done Chinese herbs for the hot flashes. And they all helped a bit, but my quality of life was incredibly low. I cannot even express how much pain I was in. And the chronic pain, unfortunately, leads to depression and anxiety. And it's really a big circle because I knew I needed to take this medication for my body, but it was causing so many problems for me that it was difficult. Every morning when I would take that pill, I would be like, okay, this is really hard, but I know how important it is. And I'm a rule follower. My doctor said 10 years, I'll do 10 years. Until I found the breast cancer index test. I had taken a month off from my AIs last December because I'm a huge Disney fan. It was my 50th birthday, and darn it, I was going to go spend 2 weeks at Disney World. Well, unfortunately, 2 weeks before we were supposed to leave on our trip, I fractured a vertebrae in my back. So thank you, AIs, for my new lack of bone density. I'm still recovering from that over a year later, but it's getting better, thankfully. But it was just another one of the things that really happened to my body because of what our body loves estrogen. And I get that the AIs are magic pills and what they do to help stop estrogen production. But for me, my body was saying no. So about 6 months ago, I'm sorry, what I was say was after that last break that I took, I started back on them in January. And from January through May, the pain was excruciating. Every day I was literally pulling myself up the stairs in my home. I could not be active with my family. And I have an 11-year-old son who wants to do things. And the day that I found the breast cancer index test, I literally found it on Instagram because I have a huge breast cancer feed, I guess, because I host a breast cancer podcast and the work that I do, it came up as a sponsored ad. And I was like, this is interesting. What is this? And I fit the parameters. Both of the times that I were diagnosed, I was stage 1, low grade. Okay, great, check. I had just hit my 5 years on the AIs, check. And I'm like, I am going to go check this out because I need this. I need some relief from my pain. So I went in and I talked to my oncologist, and she was like, okay. I literally cried through the entire visit because I was beside myself with the choice of, do I continue to take this medication and feel like this, or do I not take it and take the risk and be fearful all the time? So we ordered the test. And I have to say, from day one, when the representative from Biotheranostics reached out to me, her name was Tara, was easy and so reassuring. We talked about something that a lot of patients are really concerned about is the cost. And they have a wonderful financial assistance program where they literally take in your household income and then there's a sliding scale. And I was like, oh, I'm not going to qualify for that. My husband makes a good living. I ended up paying potentially $100, which was a huge relief because I don't have a lot of extra money to spend on cancer stuff. So anyway, we ordered the test and I waited on pins and needles and literally check in with my doctor. And when they got my results back, I was a predictive no, which means I would not benefit from another 5 years. And my prognosticative, I'm totally getting that word wrong. I blame cancer brain, was a 2.9%. And I literally sobbed because I knew that I could stop my medication. I'm good with a 97% chance of nothing happening again. I'm weighing the quality of my life, which was low, versus the results that I got back. It was a no-brainer for me. And my doctor agreed and was definitely, with your results and the quality of life issues you're having, it is completely reasonable for you to be off the AIs. I cannot talk about how happy I am and the changes that it has made in my life. So I've been off the AIs well, I say I cannot talk about it, but that's all that I do is talk about it now on my podcast and the patients that I work with, because it literally has been life-changing for me. I've been off my meds now for almost 5 months, And it literally is like a new day when I can get out of bed and I don't hurt. My husband and I, my family, we took up kayaking this summer, which seems rather daunting considering I've had a bilateral mastectomy with a lot of work done up here, but I can do it because I'm not in pain anymore. I went on a hike this weekend in Sedona to a vortex. It's a 3 mile hike up and down mountains. And my girlfriend that I was with, she has no physical limitations, and I think I felt better than she did. Because I think it was the joy of being able to go and experience what I had been through and not be in pain. I just the fact that my hands and my feet don't hurt all the time. It's not hard to go cook dinner anymore because I'm not in pain. And the outlook for the rest of my life is great because I just don't have that fear anymore because the BCI test has given it back to me. I it literally is it's like the best gift I was ever given because I feel like I was given my life back. And so I am so fortunate, and I have had the best assistance from Biotheranostics and meeting with the team in preparation for this. I literally can't stop talking about how much I love this test. And I'm just so incredibly thankful. And I cannot recommend it enough. If you meet the qualifications, talk to your doctor because you will not regret it and it will be life-changing. So I guess I think I've been through everything. I probably missed something, but I'm just super excited about it. And if you have questions, obviously I'm here, but I will pass it over to my friend who I just met, Andrea, and she is going to tell her story as well. So thank you so much.
Thank you. Michelle, what an amazing story. That was wonderful to hear. So my name is Andrea Kendrick, and I too appreciate very much the opportunity to be able to tell my story, which is a very different story. I tell it tonight in the hope that what I say, something that I say will resonate with somebody and help them out on their journey as well. So one of the first things you're going to notice about me is my accent. So I will tell you right off that I'm a child of Appalachia. I was born in central Kentucky. I was raised in southern Ohio, and I'm living now in northeast Tennessee. And as much as I try to erase this accent, it's ingrained. So you get to listen to this southern accent no matter how it affects your ears tonight. The other thing that I kind of want you to know about me is that I am a chemist, and I spent my career working for a Fortune 500 chemical company. So much of my training and my career was spent in experimentation and analysis of data. And so I believe very much in well conducted scientific studies. And I think it's important for me to note that that's the way that I inform my decisions, is pretty much through um, an analytical approach rather than an emotional or intuitive approach. And that's important because I think that it impacted my cancer treatment decisions as I went along as well. My cancer story began in 2015 with a routine screening mammogram. Like Michelle, I had a deep tumor that was near the breast wall as well. After tests and after I had a lumpectomy, I was diagnosed with the ER positive, um, node negative, stage 1A breast cancer at the age of 61. My maternal great grandmother, and several other relatives had also had breast cancer. So it was pretty well throughout my family history. And I too wasn't terribly surprised when I had breast cancer. After I had surgery and then lumpectomy, I had the Oncotype DX test, which indicated that I was high risk for recurrence. And that led me to have 4 rounds of chemo. They were spaced out 3-week intervals. And then after chemo, I went through 6 weeks of radiation therapy. In December of 2015 is when I started taking the Arimidex. It was really easy for me to add that. I put that pill in my pill box and started taking it right along with other routine medications that I was taking. And I have really experienced no side effects during that time. And in fact, I improved my health significantly during that time. My oncologist, too, had shared with me the studies that said it was long-term studies of nurses that showed that maintaining a healthy weight and exercising 150 minutes moderate activity a week were very effective in preventing recurrence. And I took that to heart. I started eating healthier. I lost a lot of weight. um, I think I had begun losing a little bit of weight before I had breast cancer, but all told, I brought my weight down over 100 pounds. And I improved my exercise routine. I hated exercise before, and now I don't feel right unless I walk every day. I walk on the treadmill every day. I lift small weights every other day. So I really built a lot of that into my lifestyle and tried to change my lifestyle to be healthier and to do everything I could to prevent cancer from reoccurring. So in 2020, I was looking forward to completing that last milestone in my treatment plan, and that was with ending Arimidex. And as I was approaching that 5-year end date, it just also happened that I was switching from my original oncologist to a new oncologist. And that was just happening because my original oncologist was limiting his practice just due to some personal reasons. I never learned exactly why, but he was bowing out a little bit. Um, but he had talked to me about the fact that I would likely end my treatment in 2020. But he'd also said, "Oh, we'll give the new oncologist a chance to review your case and advise you on what to do after that." But I was really fully well expecting to end taking Arimidex after 5 years. Um, it was interesting though, but between the time, it just happened to be very fortuitous that between the time I had my last appointment with my old oncologist and my first appointment with my new oncologist, that's when something caught my eye about the breast cancer index. And I'd already been told, monitor what's going on in the news. There were big conferences. I think they were, like December and May. There's 2 big conferences a year. Pay attention to what's in the news because if there's anything big, you're likely to hear it. So I pretty well had my radar up for anything that had to do with breast cancer. And something about breast cancer index test caught my eye. There was a link there to the website. So I went to the website. I read everything that I could find about the breast cancer index test. Um, and I was impressed that there were correlation studies done so thorough to correlate genetic information back to, risk of recurrence and to whether or not extending therapy would help. So I was very much interested in it, but I'll tell you, at that point, I wasn't sure how the test was conducted. And because my lumpectomy had been 5 years prior, I wasn't sure I would be a candidate for that. So I did meet with my new oncologist. I was beyond delighted when he mentioned breast cancer index. And I think he did so kind of gingerly because he was wondering how I would react. I was a new patient. He didn't know me. He was wondering how I would react emotionally to the idea of extending therapy. But he what he didn't know was that was kind of my test for him. If he didn't bring up breast cancer index, I had said to myself, I'll go one time to this person I've been assigned to, and then we'll decide after that if I go back or go to him. But he brought up the breast cancer index test, was very knowledgeable about it. He also explained to me that for a lot of people, that recurrence tended to happen in years like 6 and 7 once you stopped the anti-estrogen therapy. And I hadn't been privy to that data before. I couldn't find that anywhere as to when it tended to recur. But that was what he told me, was that once you stop, for a lot of women, it comes back. Um, and then the other thing that he informed me about was that I didn't know, was that my tumor had been frozen and was under a 10-year retention period. And so when I learned that, I was just all excited about breast cancer index test. For me, it was, there wasn't any question at that point. I was like, absolutely, yes, I want that test. The copay was significant, and I'm pretty frugal, but I didn't even think twice about writing a check to find the answers to those questions. So I continued taking Arimidex while we waited on the test results. And of course, I was absolutely hoping that it would come back. Low risk of recurrence, no benefit to continuing Arimidex. I think those are the, that's what everybody's looking for. Those are the ideal results. Unfortunately, those weren't the facts for me. My test came back, fairly high risk for recurrence, and continuing taking Arimidex would be a good benefit. But, I readily agreed to continuing that. It was just, I was looking forward to being sort of finished with my treatment journey. But having that data in hand, then it was a no-brainer. I knew that I needed to continue. And it wasn't really any problem for me to continue. I was already in the habit of taking the medication every day. Again, it's in my pill box right along with some other meds that I'm taking and was taking routinely. So it was not a problem to add it. I haven't really had any side effects to speak of. Nothing that is, I have my little problems here and there, but nothing that's continuing or ongoing. My oncologists and my general practitioner are always, very on top of anything that I'm having a problem with. But for the most part, I can't say that I've really had any side effects at all, and that taking the medication has really not impacted my life at all. Now where I am now is I'm about halfway through my second 5-year period, and I'm beginning to wonder a little bit how I'm going to feel when it comes time to talk about stopping the medication again. But then I also wonder what kind of new research is going on now and what's going to be out, by that time, that might impact my cancer treatment journey again. So it's just curiosity for me, to kind of wonder what's next. But I've really had a really good time, good experience with taking the Arimidex, and I know I'm doing the right thing because of the results of the breast cancer index. So that's my story to date. And I appreciate you allowing me to share my experiences with you. And I hope that it has helped somebody to hear a little bit about what my story is like. So with that, I'll turn the session back over to Dr. Chap for Q&A, I guess. Thank you.
Well, wow. All I can say is wow. I mean, Michelle and Andrea, I mean, I just almost got a bit of goosebumps. I mean, thank you so much for sharing your story. It's just, I have no doubt that the women, and maybe a few men, but the women who are listening in have been impacted by sharing your personal stories. So thank you so much. I'm sure, boy, these will be stories that really hit home and again, really show, the personal side of having this test done and how it can change somebody's life. So thank you so much. So we'll just start to wrap things up. So who is eligible to have this test? So it doesn't matter what the menopausal status, pre, peri, going through that lovely change of life, or postmenopausal. It can be done in lymph node positive disease, and it's up to 3 involved lymph nodes. So for somebody that has more than 3 involved lymph nodes, the test should not be done. Any tumor size up to T3. So there can't be skin invasion or chest wall invasion. Any tumor grade, HER2 positive or HER2 negative. It does need to be hormone receptor positive, chemotherapy or no chemotherapy. And an important point that I think some people don't realize, including healthcare providers, is that when this test is done, The patient really needs to be disease-free clinically of recurrence. So no suspicion or evidence that there's a distant metastatic stage 4 disease. And it can be done regardless of what things look like under the microscope. Ductal cancer, which is the most common type of breast cancer. Second most common is lobular. So these are all of the eligibility criteria for this test. All right, so just, well, I don't know if we want to go back or not. All right, so when to get started. And, I think as we saw, with both of our patient advocates and those who shared their journeys, the most common time to get this is when you start getting closer to the 5-year mark. And that's really when this test was done. In order to have this test done and to be eligible for the different studies, patients need to be disease-free at 5 years. But I like to forewarn my patients and really tell them much earlier on as we get closer to the 5-year mark, there's another test that we can do to help us make the decision so they're not blindsided and 1 month before they're going to hit year 5 to know there's another test that we can do. So again, it's really telling us whether or not, as we've heard, there can be benefit to extended endocrine therapy. And again, it's important, to know about, and if your physician hasn't brought it up, to really be an advocate for yourself, whether it's from hearing the patient testimonials tonight, Instagram, TikTok, things that I don't even know how to get on, to talk to your physician about this. And if they don't know about it or don't do it, maybe, time to get another physician. So obviously talking to your healthcare provider, I think really important that Andrea pointed out how the test is done and what it's done on. I mean, so many things have been done, to women with this disease that the last thing you want in the fear when this test is brought up is, oh my gosh, what needs to be done to me? So again, it's done on a wax block, a piece of the tumor is always saved in a wax block from that initial surgery. So saved, so nothing needs to be done to you. No additional procedure. And, the results are sent to the physician who should then sit down and hopefully in a timely fashion, discuss the results so you know what to do next and not be waiting by the phone. And just to add as a comment, the company is great to work with. And I also warn patients that you're likely going to get a call so they're not blindsided. So if I order it after I'm done seeing the patient, I call them and let them know that they may get a call so that they're not thinking, what in the heck is Dr. Chap ordering me, and getting all nervous about something I haven't mentioned to them. Thank you so much, everybody. Have a great night.